Vamos a empezar. Sabemos que el horario que teníamos era de empezar a las 9, pero bueno, conforme está el tiempo y además que está llegando gente, pues hemos dejado 10 minutos de deferencia. Pero no podemos retrasarnos más porque si no nos va a pasar como ayer, que al final terminamos casi una hora más tarde de lo previsto. Bueno, vamos a empezar con una ponencia, con una conferencia que yo creo que es importante porque si bien ayer se estuvo hablando de un contexto, diríamos, más neurobiológico, más de consecuencias, con algunos aspectos preventivos, con algunos aspectos de intervención comunitaria, escolar, incluso por la noche con algunas propuestas de ley, creo que llega el momento de tener en cuenta que el cannabis como droga pues puede provocar una adicción y como muchas de las adicciones que tenemos no tienen un tratamiento específico desde el punto de vista farmacológico, aunque sí que hay intervenciones psicológicas que ya tienen cierta evidencia y están contrastadas, pero creíamos que era importante saber cuál es la actualidad en este tema y para ello pues contactamos en Estados Unidos con el doctor Dustin Lee. Él es psicólogo y filósofo. Desde el año 2005 está licenciado, graduado por la Universidad de Nuevo México y además se ha encargado de hacer búsquedas, de hacer investigación alrededor de la psicofarmacología de la nicotina en el Instituto Nacional de Drogas de Abuso en Baltimore. Además, ha hecho un trabajo postdoctoral, sobre todo relacionado con intervenciones cognitivas, conductuales. Y creo que es una persona que, si leyese todo su currículum, para lo joven que es, tiene una serie de publicaciones inmensas. Él trabaja ahora en estos momentos en el Johns Hopkins, en Baltimore, y está especializándose sobre todo en el desarrollo de objetivos, de focos de desarrollo en el tratamiento, en la prevención y en la intervención, sobre todo de tabaco y de cannabis. Y por eso decidimos que era la persona indicada para que nos hiciese una revisión de cuáles son las intervenciones, no solo desde el punto de vista farmacológico, sino también desde el punto de vista conductual, para saber si realmente, cuando tenemos una persona con un trastorno adictivo provocado por cannabis, estamos actuando correctamente o simplemente todavía no tenemos evidencias. De todo esto nos hablará el doctor Dustin Lee, al que le damos la bienvenida. Y cuando quieras, Dustin, muchas gracias por estar aquí.
Good morning. Hello. Buenos días. Thank you, Francisco, for the nice introduction. I also want to thank Manuel and the organizing committee here for inviting me. It's a great honor to be here with you this morning. I am an English speaker. I was told if I speak very slowly, so I'll try in my presentation this morning to have better translation. But sometimes I get excited, so if I do, please forgive me. But it is a great honor to be here. This is my first time in Spain, and I love Galicia. I will bring my family back here for pleasure and maybe for business next time too. Thank you. So this morning I'm going to touch on work that we and others in our field are doing for the development of drug or pharmacotherapies for cannabis use disorder. Let's see if I can move this. Better? just hold it. So I'll describe the outline or the summary of what I'm going to be presenting today. First, I'm going to describe what we mean when we say cannabis use disorder, what the prevalence of that is worldwide, a little bit in the United States, and then the characteristics of the disorder. I'm going to provide an overview. This is a very interesting topic, especially in the United States, to step back and ask ourselves, what is cannabis? Much better. Thank you. Excellent, excellent. It takes a team to give a good talk. So next I'm going to summarize the trials that evaluate these pharmacotherapies or medications development for cannabis use disorder. And I want to have a little bit of time to focus on areas that we are conducting research in emerging clinical areas that might provide some novel therapeutic targets, mainly tobacco use and then sleep. So I'm going to focus a little bit on those two areas today. And mainly I want to discuss the challenges related to development in this field. And I think it was touched on already. And I might be ruining my talk right here by saying this, but we don't have very many efficacious therapies for cannabis use disorder at this time. So if you want to sleep for the rest of my talk, that's the bottom line. So I'll begin with the prevalence and characteristics. Prevalence of cannabis use is about 4% worldwide among adults. It's higher, about 14.1% and 9% in past year and past month use, respectively. Data on this next topic ranges, but around 10 to 30% of individuals report experiencing some symptoms of a cannabis use disorder among those who use cannabis. The data is mixed, but it looks like at least a fair amount of individuals that start to use cannabis will experience some problems. The epidemiology of cannabis use disorder is challenging to get a grasp on, especially the prevalence of that, because of different classifications, depending on whether it's a DSM or the ICD, and different ways to assess and screen for that. But the World Health Organization, and I think everyone in this room probably understands that it is a public health concern, and treatments are warranted in this area. And it appears to be increasing, especially in our country, in the United States. We're seeing very quick changes along with legalization. So here's some recent data in the United States, and I just want to point out here that cannabis use disorder, around 4.2 million people in the United States, age 12 or older, had cannabis use disorder in the year 2015. That's already 4 years ago. So again, we're talking about probably 5 or 6 more states by this time have now legalized cannabis. So these numbers are increasing. And for those substances for which people are entering treatment, cannabis is second only to alcohol. So demand for treatment is high, especially in this country. I like this graph, and I want to show this. This is a little bit older data, but I think it gives a really interesting example of what's happening. So we have, this is a little bit older data. It only goes to 2010 from 1986, but there are 3 interesting lines on here. This first line are millions of current cannabis users in the United States. So you can see the increase there. The second line is the average potency of cannabis that is seized by our drug enforcement agency off the streets. And you can see a rapid increase in potency in the last 30 years or so. Finally, this line here represents the number of individuals that are entering treatment for cannabis as the primary drug of issue. So all three of these lines are showing a considerable story here. Potency is increasing, treatment admissions are increasing, rate of users are increasing. Again, this ends at 2010, it's almost 10 years old. Colorado didn't legalize until 2014. We now have, I believe, 10 states that have legalized recreationally. So the amount of the potency is even increasing even more along with treatment admissions. So we are seeing a vastly, rapidly changing area. So what is cannabis use disorder? The features of cannabis use disorder are similar to other substance use disorders. There's difficulty controlling use, repeated failure to quit or to reduce use. People spend a lot of time trying to get the drug or using the drug. There's some withdrawal and craving. And the tolerance and withdrawal, I think, are very important to my topic today because they are a focus on many of the pharmacotherapies that are currently being tested for treating cannabis use disorder. Cannabis withdrawal and perhaps still is, somewhat of a controversial topic. Many people and advocates of cannabis believe that there is no withdrawal syndrome. Well, work, especially by my mentor and colleague, Alan Bundy, in the United States, have spent years developing screening assessments and testing and laboratory studies to evaluate the cannabis withdrawal syndrome. And there is a valid and reliable withdrawal syndrome shown in well-controlled laboratory studies. The time course of this suggests effects last up to a month and may peak within the first week. The severity of effects generally are equivalent to tobacco use and tobacco withdrawal, although there are individual differences between people, so some have more severe withdrawal than others. 30% of all current users and more than half of daily users report withdrawal when they quit using cannabis. And we have data from clinical studies and from other observational research that suggests that withdrawal contributes significantly to relapse. So our DSM, the Diagnostic and Statistical Manual, the 5th edition, defines cannabis withdrawal criteria. I won't go through each of these individually, but I'll note the most severe and the most frequently reported effects are irritability, anger, aggression, nervousness and anxiety. Sleep difficulty is big. Insomnia is big during withdrawal, and it is a significant contributor to relapse. And of course, there are other issues that are involved in and reported in cannabis withdrawal. So now I want to move, before getting into how we treat this, I want to move in and just talk about what is cannabis. This is cannabis, right? This is cannabis. That's what we know. These are American ambassadors of cannabis use, if you will. And if you don't know, these are musicians. The top here is rapper Snoop Doggy Dogg. The bottom is country singer and songwriter Willie Nelson, both of whom are very outspoken advocates for cannabis use. When we think of cannabis use in our country, in the United States, we frequently think of these individuals and these plants and things that look like this. But in reality, the cannabis marketplace looks more like this. There are still joints, but there are vaporizers. Whatever this is, I don't know. There are also concentrates and oils, patches, all sorts of edibles, again, gummies. All of these are available in the marketplace, depending on which state you reside in the United States. Suppositories? I don't know. I don't think there's very high prevalence, but they're there. And then pharmaceutical cannabinoids, which we heard yesterday, we heard a lot from, and I'll be speaking in the context of treatment on these today. So what do we know about how cannabis affects people? Well, there are the positive effects that are associated with cannabis. Makes you relaxed, easier to laugh. Perhaps you'd be laughing at my bad jokes this morning if you had some cannabis. I don't know. Increased appetite. And there is, and I must note, a great potential benefit for medical conditions. A little bit overstated in our market, but that potential is there. For negative, of course, dry mouth, red eyes, more severe paranoia, anxiety, hallucinations, cognitive impairment. We see this in our laboratory studies where we provide cannabis to participants, acute cannabis, and we see paranoia and anxiety at high doses, and we have to treat it medically very often. So this does exist. And these effects are dose dependent, and they vary widely across individuals. It is challenging for us to determine which individual might have a negative reaction at any given time. How does this plant act as a drug? Again, we heard a lot from this yesterday, so I'm happy to follow such well-informed speakers, so I don't have to spend so much time on this. But CB1 receptors are abundant in the brain, the spinal cord, and peripheral nervous system. CB2 receptors are mostly located in the peripheral immune system and gut, but they're also located in the brain. And there are some compounds in cannabis, of course, THC being the main one, that mimic these chemicals in our bodies, and they bind to these receptors. Here is a cartoon of the endocannabinoid system. Again, it's early. I know you might have had some coffee. I don't want to spend too much time on this morning, but just to note, there are places in here, there are anandamide and 2-AG are endocannabinoids that are of great interest in developing pharmaceutical treatments for cannabis use disorder. Can we manipulate these? If so, how? And will that help alleviate withdrawal or help reduce the reinforcing effects of cannabis? These are all questions that we are seeking to find answers for. So with that, I'll turn to what we know from our investigations in the field, I speak broadly, of cannabis use disorder interventions. So there are efficacious evidence-based treatments that have been developed. Abstinence from cannabis is most widely accepted as the key primary outcome for these interventions. And to note, relapse rates, no matter what the intervention, are high. So there's a great need for focus on improving treatment efficacy. I'm going to start by describing a behavioral treatment, which is odd for a medications development talk, but this platform is really the most efficacious treatment we have to date. These effective behavioral interventions include motivational enhancement therapy, cognitive behavioral therapy, and contingency management, where incentives, generally money, Sometimes coupons or other incentives are provided contingent upon abstinence and verified abstinence from cannabis. Combining these three interventions together engenders higher rates of abstinence. This is data from a study conducted by Alan Bundy's group in the United States. It shows the difference in percent of participants that were abstinent at end of treatment, 6 months post-treatment, and a year post-treatment when receiving MET alone, the combined MET and CBT, and the treatment that combines all three. The key point here is that the combined treatment engendered abstinence rates around 40% at end of treatment, down to about 30% at 12 months. So again, 70% of people enrolled in treatment will relapse within a year. So there's lots of room to improve this platform. Pharmacotherapies are one way we might be able to improve abstinence rates. They've been evaluated in, I think, 22 clinical randomized controlled clinical trials to date. Here are the drugs. If I had all day, we'd go through each of them. I don't. We'll go through a few of them, but suffice to say, and again, I'm jumping ahead of myself here, there's no pharmacotherapy that is currently approved by our Food and Drug Administration for cannabis use disorder treatment, and there's no pharmacotherapy recognized globally as an efficacious treatment either. But it's not for lack of trying. Medications tested include multiple THC agonists, inverse agonists, antidepressants, anticonvulsants, anxiolytics, and many other targets. Again, I'll touch on a few that seem most promising this morning, and I'm happy to discuss further with anyone at any point today. So what are the targets when we talk about medications development? Well, we can look at other drugs of abuse for some guidance here. First, we have drugs that will block the subjective, the reinforcing effects of THC. They might reduce behavior, cannabis administration behavior. And these drugs can be thought to be similar to antagonists such as naltrexone for opioid use disorder. Now, an inverse agonist, rimonabant, is most well known in this area, and it did show some initial efficacy for cannabis abstinence, but it was pulled from the market in Europe because of concerns related to suicidality and other psychiatric concerns. The other target and the area that receives the most attention is to help reduce the effects of cannabis withdrawal. Well, how do we do that? The first and most prevalent way to approach this is with agonist replacement of THC. Replacing smoking cannabis or ingesting cannabis with a safer form of THC. This may prolong abstinence or reduce relapse by decreasing withdrawal and cravings that are seen during cannabis abstinence. So the THC agonists that are currently on the market and being tested for cannabis use disorder, dronabinol, nabilone, Sesamet. There's also nabiximols or Sativex, and then just recently approved in the United States, Epidiolex, which is cannabidiol. I'll talk about each of these as they relate to treating cannabis use disorder here. So dronabinol is a partial agonist of the CB1 receptor. It does have clinical utility and indications for reducing nausea and vomiting during cancer chemotherapy. Also, it promotes appetite in anorexia and in AIDS wasting disease. What are the pros related to cannabis treatment? Well, in laboratory studies, it's very effective at decreasing withdrawal symptoms and also decreasing the reinforcing effects of the drug. So in laboratory assessments, individuals are less likely to ingest cannabis when they are given dronabinol beforehand. But, and this is a big concern across this line of research, when given to participants in outpatient randomized controlled trials, it doesn't increase cannabis abstinence at any significantly higher level than placebo. So it might reduce some withdrawal symptoms, but that doesn't translate to lower drug taking in the real world. And there are some other concerns. There's low bioavailability, and there is some abuse liability and some diversion, maybe. Nabilone is a synthetic analog of THC. It has a higher bioavailability than dronabinol. It's a longer duration of action and lower abuse liability. So we have a little bit step up here. It also decreases withdrawal symptoms and drug taking in human laboratory studies. But again, oh, and it's well tolerated. So there's very few adverse effects or adverse events in clinical trials. However, again, there's no significant improvements when provided in, this is a pilot randomized controlled trial, so small study. We didn't see a difference from placebo. But there are some positives, and it does look like this, like nabilone, may have some efficacy. So here, larger clinical studies are warranted. But as for now, it doesn't appear that this is going to be a silver bullet. Nabiximols are recently, have recently come into play as potential pharmacotherapies for cannabis use. Nabiximols are a 1-to-1 THC to cannabidiol ratio. It's an oral mucosal spray. And CBD is an interesting, and it's not fully understood, mechanism of action at this point. It's becoming very popular, especially in the United States. There are stores, it's seemingly on every corner, that now sell CBD for everything, every condition. You can cure, it's amazing if you listen to people. It will cure everything. So, it's yet to be seen. But it does have some psychoactive effects. It is an anxiolytic. It's not intoxicating, and it doesn't appear to be reinforcing in either animal models or in human lab studies. The clinical indication for nabiximols, which again have both THC and CBD, are for spasticity due to neuropathic or multiple sclerosis and neuropathic pain. There are research is very is burgeoning, so it's just beginning in this area. There are a couple of studies by colleagues in Canada and Australia that have been published, and larger trials ongoing. And it looks that, again, Sativex, like other, or nabiximols, like other THC agonists, it reduces withdrawal, so it's a good thing. And it reduces the time course of withdrawal. But this is, again, in inpatient studies and a small outpatient clinical trial. It improved treatment retention, so more people stayed in treatment. That's always a good thing, especially if we provide a behavioral platform as well. It gives more time to provide behavioral treatment. But again, as far as we can see so far, there's not a significant improvement in abstinence relative to placebo. Is abstinence the goal? I'll touch on that a little bit later, but this is what we're seeing. But we do need more trials in this area. Other medications, gabapentin is an anticonvulsant. It increases GABA biosynthesis. It was very exciting for a little while. It seemed very promising. In laboratory models, it reduced withdrawal and reduce cannabis use. And it looked to be an interesting, unique drug that might have some efficacy. But in larger trials, there's a large dropout rate. It wasn't tolerated very well. There were some aversive side effects. And this really diminished its potential as a pharmacotherapy outside of well-controlled laboratory studies where we could closely monitor side effects. So in a clinical setting, maybe not so much. There are other medications. Colleagues at the Medical University of South Carolina have been interested in looking at N-acetylcysteine, which is a prodrug. It's available in the United States over the counter. No prescription necessary. It restores glutamate homeostasis. So in animal models, it reduces reinstatement of drug seeking. And it also increased abstinence. In 2 studies have been conducted. It increased abstinence in an adolescent study, which is very unique. There's not many adolescent studies looking at medications for cannabis use disorder. This is a very unique study. However, when the same medication was evaluated in adults, again, I echo myself. There was no difference between placebo and NAC. But there is potential efficacy here, maybe for younger individuals. We need to understand the mechanisms of action better to really understand how we can use this in treatment. But stay tuned, this is a promising area. And finally, one of the newest drugs that is being tested is the FA inhibitor, fatty acid amide hydrolase inhibitor. This inhibits metabolism of endocannabinoid anandamide. So going back to the cartoon that I presented toward the beginning of my talk, this would increase the synaptic availability of endogenous cannabinoid anandamide, which would be the potential mechanism of action here to reduce withdrawal and reduce reinforcement. We have colleagues at Yale that have done some of the seminal human work in this, and there is some demonstrated, again, decreased withdrawal in inpatient clinical studies. Right now, I'm part of, my site is part of a multi-site clinical trial that's evaluating this drug in a randomized controlled clinical trial. So give us 2 years, and then hopefully we'll have some answers with this drug. But it does look interesting, and the National Institute on Drug Abuse and the FDA are both very interested in this drug as potential pharmacotherapy. That said, again, we're at the point where we don't have many efficacious treatments for cannabis use disorder. So this warrants looking at other areas and other ways to treat cannabis use disorder. So what are possible targets? Well, we have a behavioral platform, so we can enhance the delivery of that platform, improve access. We can also target the endogenous cannabinoid system. Again, I've talked on this a little bit with the FA inhibitor. Improve brain function, target concurrent substance use, target specific withdrawal symptoms. I'm going to be speaking on 2 of these areas where we have recent clinical trials that we've looked at. Well, first I'll explain quickly. We've developed a computerized behavioral intervention that we now use as a base platform for testing adjunct pharmacotherapies for cannabis use disorder. So given that platform and the efficacy of the behavioral intervention, now our focus is to improve that number. We're looking at this in 2 areas, targeting tobacco and targeting sleep. So let me explain the computerized intervention for a second here. This is combination motivational enhancement therapy, cognitive behavioral therapy, and contingency management that is, like I showed at the beginning of my talk, efficacious for treating cannabis use disorders. The limitations of this are access and cost. So it's costly and time-consuming to train and deliver this therapy well in a clinical setting. And contingency management is often viewed as cost prohibitive, and even that is sort of underestimating the amount of pushback that we receive for trying to give people money for quitting drugs. In America, it's a puritanical society, and a lot of people don't look very kindly on giving people monetary incentives for changing a behavior. Although we have good data to back up that the cost of this is much lower than public health costs associated with treating cannabis use disorder in hospitals or criminal circumstances. Regardless, what we found is that by providing these computerized intervention, this increases access without a loss of fidelity, and it can reduce costs that can be then used for contingency management. So with this platform, we've now tested 2 different adjunct treatments. The first is cannabis and tobacco co-use. Cannabis and tobacco co-use is interesting. In America, it's a little bit lower than what we see here in Spain and Europe, in which cannabis is almost always paired with tobacco for consumption. In the United States, about 70% of past month cannabis users also use tobacco. And here is an interesting graph. This is the rate of tobacco use among past month cannabis users between 2003 to 2012. In the United States, one of our biggest public health triumphs has been the decreasing number of cigarette smokers, and we're down to a prevalence of about 15%, from upwards of 50% in the 70s. So we've made great progress in this area. But in cannabis users, not so much. It's about 70%. It's been about 70%. It probably will be about 70%. Why is this important? Well, tobacco use is a negative predictor of cannabis treatment outcomes. So people who use cannabis have poor treatment outcomes. And I must mention my colleague Sergio kind of did some of the initial work in this area and which we piggybacked on. So thank you for that. It's been very helpful. Tobacco quit rates are minimal during treatment without any intervention focused on tobacco, so nobody quits. And tobacco smokers in treatment, we found in observational survey studies that individuals who were in treatment for cannabis were interested in quitting tobacco, so that interest is there. There is some concern that if you target both, we're going to get poorer outcomes, potentially because we're going to be compounding the withdrawal that we see in cannabis with also tobacco withdrawal. Or there's a concern that people won't want to quit both drugs at the same time. So our initial work alleviated some of that concern, and we're also very interested in seeing if targeting tobacco may improve cannabis outcomes. For this, we ran a randomized controlled trial where we looked at a simultaneous intervention versus sequential. And what I mean here is for the simultaneous intervention, we ran our computerized behavioral platform, and then individuals were also able to receive nicotine replacement therapy free of charge and behavioral counseling for tobacco use. In the sequential group, this acted as our control group. Participants only received the computerized behavioral intervention. And then in the subsequent 12 weeks, in the sequential condition, they were allowed to access and receive NRT and behavioral counseling if they so chose. We did this for a couple reasons. First, this platform allowed us to have a control condition built in, but this also perhaps answers the question of, is it better to quit both drugs at the same time or treat both drugs? Or is a sequential approach more efficacious? What we saw was very intriguing, kind of in a bad way, though. We saw more abstinence in the sequential group compared to the simultaneous group. This was not statistically significant, but might be clinically meaningful. We did not see much in the way of prolonged abstinence. And when we looked at a 16-week follow-up, our abstinence rates were very poor. We did see a significant reduction in use, so abstinence, perhaps not, reduction, yes. That might be a little bit helpful from a harm reduction standpoint, but it's not what we were looking for. There's a couple reasons why this might be the case. We ran this study in Seattle, Washington, and Seattle at this time had just legalized cannabis. And so a lot of times in this line of work, we received participants that were that had court-ordered deferral, so they were referred by the criminal courts to our treatment. When it was legalized, we didn't have this issue anymore. So this now became just people with clinical, self-motivated people with clinical use disorders who came in. So much more challenging group of individuals to treat. So this might be a potential reason why we saw this. We did see, with the simultaneous treatment, we did see a number of quit attempts for tobacco, and we did see some good abstinence and reduction. So we saw some positive things there. Overall, there were lower abstinence in this compared to previous trials. And the bottom line here, as I'm getting short on time, I want to keep moving forward, but the bottom line here is we need to account for more intensive behavioral and pharmacological interventions targeting tobacco during treatment for cannabis use disorder. So varenicline, other contingency management. We're about to start running a varenicline trial, which is Chantix. So we'll have some more information there. The other area is cannabis use and sleep. So cannabis use is associated with acute and long-term changes in sleep function. And daily users report strange dreams, insomnia, and this is a main reason why relapse occurs in a good portion of the population. So we were interested in targeting individuals who used cannabis specifically to help them sleep or spend a long time recovering during periods of abstinence. And we looked at zolpidem, which is Ambien, it's a sedative hypnotic, for 12 weeks in a group of cannabis users. And again, we saw zolpidem here increased abstinence rates throughout the study. This is point prevalence abstinence. So this is our active drug group, and this is our placebo group. And we see some separation by end of treatment. But again, we're still looking at that 30% level. We can't seem to get above that level. We did see some improvements in sleep, or some decreases in sleep efficiency in placebo. This is the amount of time sleeping compared to the amount of time in bed. In the active group, we didn't see that. So zolpidem is helping improve some sleep disturbance, but then we saw a decrease when zolpidem was tapered off. So essentially, we're just moving the sleep problems 12 weeks. I'm not sure if that's very helpful. So zolpidem, it doesn't look like the answer here, but sleep is very important as a take-home. So we're looking into more behavioral interventions and other adjunctive treatments. The final area I just wanted to focus on just very briefly here is outcomes. So we have consensus outcomes for tobacco and alcohol. For tobacco, no level of tobacco use is safe. So prolonged abstinence is the only accepted outcome for treatment trials. For alcohol, it's legal in most areas. Abstinence is a primary key outcome for evaluating drugs, but reduction in use is an acceptable outcome under FDA standards in the United States. Elimination of heavy drinking days or binge drinking is an accepted outcome for medications development. Is there similar outcome in cannabis, especially if it's legal in the United States, anywhere, in any country, Canada, wherever? Now we have to talk about potentially cannabis, there is a safe level of use. Is there? We don't know. How do you measure that? We don't know. It's tough, as I think Sergio talked about yesterday, in evaluating screening tools and evaluating, measuring, what is a joint? How much is in a joint? If you vaporize cannabis, how do you measure that? Is it in grams? We don't know. So is cannabis use the answer? And if so, how do we standardize to create a standard unit akin to what we might see in alcohol? We don't know. We need to do some work here, but it's something to think about. If reduction in use is a key outcome, then we need to think about what that reduction might look like and what a safe level is. For this, we need to look at, there's a wide range of outcomes that are reported in clinical trials, but they haven't been very well standardized across trials. So this is an area where we can pool data together and look at psychosocial outcomes and quality of life improvements to see if our treatments are maybe making some improvements aside from abstinence, where we're not seeing much. So my take homes here: cannabis use disorder is prevalent. There's demand for effective treatment. There's currently no pharmacotherapies available. Relapse rates are high. There are some promising treatments, but outcomes other than abstinence should probably be evaluated in this area. And with that, I'll just put up my acknowledgement slide. Thank you very much for your attention, and I'm happy if there's time to answer questions.
Thank you.
All right, thank you.
Nos quedan 5 minutitos, nos hemos ajustado bastante al tiempo.
Okay.
Sí, porque desde aquí no.
Yep.
Sí. Vale, Nacho.
I could.
Muchísimas gracias, profesor Lee.
Wait, sorry.
Okay.
Yes.
Muchísimas gracias, profesor Lee. La pregunta se refiere... Ok.
Sí, adelante, Nacho.
Adelante.
Ya te oigo, sí.
Vale. La pregunta se refiere si hay algún estudio en estos momentos que esté vinculando la terapia de aceptación y compromiso en el tratamiento sobre adicciones.
Acceptance and commitment of the pharmacotherapy. Is that? Oh, psychotherapy. What we see in our treatment studies is it's very well accepted. And generally we have fairly good retention rates in our treatments, in our behavioral, psychosocial treatments. So around 50 to 60% of individuals are retained through the end of treatment. If we provide contingency management, that's improved even more. So does that answer some of the question, hopefully?
Hello?
the compromised therapy. The compromised therapy.
Uh-huh.
One moment. Aceptan commitment therapy. Right. Si esta terapia es una terapia contextual y se está utilizando en algún estudio sobre adicciones.
Oh, not in cannabis use. Right?
Hello. Well, first of all, thank you for your presentation. And I'm glad that some of the work you were discussing eventually was useful for the tobacco and cannabis issue. My question had to do with, you were discussing before how using pharmacotherapy might be useful for dealing with these adolescents mostly that are like non-responders in treatment. But I can remember that Catherine Stein, your colleague, was working on something or developing strategies, psychological strategies for those non-respondents. Like, for example, when they start or when you notice that they don't respond in the first weeks, maybe you just refer them to a more intensive treatment, or maybe increase the intensity of the contingency management program, or you drive them to another more intensive or way of treatment. And I don't know if you're still working on that or if you have any results on how that might work.
Yeah, you're right. A colleague of ours has been, for adolescents, has been developing a sort of a step model of a behavioral intervention for adolescents with both cannabis and alcohol use disorders. So the way that works in a nutshell, and I might not get this 100% correct, again, this is adolescence, so what happens is they get a step or more intensive family intervention, so the parents become involved, and then the parents get incentives that are contingent upon their child's behavior, and the children get incentives that are then magnified if, in the event of non-response. These approaches do show better outcomes, better abstinence rates in adolescents, and these adolescents have conduct problems. They're very tough to treat. So these are sort of the more clinical, severe substance using adolescents in this population. So we are seeing some improvements there. The problem with this is implementing this in a clinical setting. So when we have good therapists and good employees and good interns and good residents, and we have a good team together, we can have, this is a successful strategy. But when it's implemented, say, in inner city Baltimore, where I'm from, where there's a lot of poverty and the clinical environments might not be as approachable to such a complicated treatment design, we lose sort of fidelity, and we lose our improvements in cessation, unfortunately. So we're thinking of ways to better implement these strategies and make them more conducive to use in real world environments.
Thank you.
The last question, please. Finish? Thank you very much for this revision, this pharmacological and psychological revision. And do you have a new cannabis family in Spain? Thank you very much.
Thank you, David.